Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about beta-thalassemia minor. Beta-thalassemia minor, also called beta-thalassemia trait, results from the heterozygous inheritance of either a beta plus or beta 0 gene, with one normal beta gene. The typical phenotype of the beta-thalassemia trait, essentially is characterized by reduced MCV and MCH, and increased hemoglobin A2. The normal beta gene directs synthesis of sufficient amounts of beta chains to synthesize enough hemoglobin A for near-normal oxygen delivery and erythrocyte survival. In the case of a heterozygous beta plus, the thalassemic gene can also contribute to beta chain production. The heterozygote appears to be asymptomatic. In conditions of hemopoietic stress, for example during pregnancy or during intercurrent infections, a mild to moderate microcytic anemia can develop. In a small minority of heterozygotes, the spleen is slightly enlarged. Beta-thalassemia minor usually presents as a mild, asymptomatic anemia with hemoglobin ranging from 12.4 to 14.2 gram per deciliter in affected men, and 10.8 to 12.8 gram per deciliter in affected women. The RBC count is within the reference interval or slightly elevated. The MCV is less than 75 femtoliter and MCH is less than 26 picogram. The MCHC is sometimes slightly decreased, but often normal. The RDW, a measurement that reflects red cell anisocytosis, is usually normal. The reticulocyte count is within the reference interval or slightly increased. In uncomplicated cases, the leukocyte and platelet counts are normal. The blood film varies from almost normal, with only mild microcytosis, to markedly abnormal. The degree of microcytosis, as indicated by the MCV, is directly related to the anemia severity. Abnormal features, in addition to microcytosis, include anisocytosis, hyperchromia, and poikilocytosis. Individuals with a more severe phenotype may have prominent basophilic stippling, target cells and small numbers of irregularly contracted cells. Target cells and basophilic stippling are generally more common in beta-thalassemia than in iron deficiency. Elliptocytes are generally more characteristic of iron deficiency than of beta-thalassemia trait, but some thalassemic individuals have prominent elliptocytes. Nucleated red blood cells are not usually found. The blood film showing minimal morphological abnormalities, microcytosis and mild poikilocytosis. The diagnosis could easily be missed without the red cell indices. The blood film showing more marked morphological abnormalities, anisocytosis, poikilocytosis, hyperchromia, microcytosis and target cells. The blood film showing hyperchromic microcytic erythrocytes with frequent target cells. The blood film showing microcytosis, hyperchromia, poikilocytosis and basophilic stippling. In the most common beta-thalassemia minor syndromes, the hemoglobin A level is 92 to 95% and the hemoglobin A2 level is characteristically elevated, and can vary from 3.5 to 7%. Hemoglobin F is elevated in about half of cases. If hemoglobin F exceeds 5%, the individual has probably inherited a hereditary persistence of fetal hemoglobin gene, in addition to the beta-thalassemia gene. Beta-thalassemia cannot be diagnosed from the hemoglobin A2 percentage in neonates, as levels are low. Hemoglobin electrophoresis on cellulose acetate at alkaline pH, showing increased hemoglobin A2 in 2 patients with beta-thalassemia trait. ASC is a control sample containing hemoglobins A, S and C. Isoelectric focusing analysis in beta-thalassemia trait, normal adult and normal newborn. High-performance liquid chromatography is an automated way of separating and identifying variant hemoglobins. It is more accurate at quantifying hemoglobin A2 than in hemoglobin electrophoresis. It can separate hemoglobin A2 from certain hemoglobins, which is not possible using hemoglobin electrophoresis alone. The panels show HPLC chromatograms in a normal subject and in beta-thalassemia trait, with indications of hemoglobin A2 and hemoglobin F percentage and elution time. The bone marrow shows increased cellularity as a consequence of mild to moderate erythroid hyperplasia, with minimal ineffective erythropoiesis. Some erythroblasts show defective hemoglobinization, poorly filled with hemoglobin, and cytoplasmic vacuolation. An iron stain may show heavy siderotic granulation. DNA probing techniques can be performed to identify the type of mutation present and validate the heterozygous inheritance pattern, but are of limited diagnostic value. Such information can be helpful in counseling prospective parents with beta-thalassemia minor. The typical phenotype of the beta-thalassemia trait, essentially characterized by reduced MCV and MCH, and increased hemoglobin A2, may be modified by several genetic and acquired factors, causing problems in carrier identification. Some phenotypes and genotypes of atypical beta-thalassemia traits are listed in the table. Iron deficiency anemia may decrease the hemoglobin A2 levels both in individuals with no defect of globin genes, and in those with beta-thalassemia trait. Folate deficiency may increase the MCV up to normal values. Liver disease also may raise the MCV and MCH of patients with beta-thalassemia trait into the normal range. Other tests, such as DNA analysis to identify the beta-globin gene mutation, or retesting after correction of the acquired factors, are warranted to make a correct diagnosis. The diagnosis of beta-thalassemia trait is usually made by first ruling out iron deficiency and then demonstrating an elevation of hemoglobin A2 levels by electrophoresis. The differential diagnosis of beta-thalassemia minor is alpha-thalassemia trait, with normal hemoglobin electrophoresis, iron deficiency and anemia of chronic disease. Elevated hemoglobin A2 levels and normal iron studies will confirm a diagnosis of beta-thalassemia minor. However, hemoglobin A2 levels may be in the normal range in patients with concomitant beta-thalassemia minor and iron deficiency. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.